Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare and community wellness. We are continuously growing, learning and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare and wellness. We are continuously growing, learning and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every PIN code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare and community wellness. We are continuously growing,
तिकडे आहे ना तिकडे ते माझ्या टेबलवर ते नावं देऊन त्या लोकांची.
So, ma'am, it's 3, 2, 1. We are live now. Over to you, Komal, ma'am.
Good evening to all. I am Dr. Komal. Welcome you all for today's Lead HF Heart Failure Symposia. It's a privilege that we have all the Indian national experts, cardiology expert with us, who are going to share their expert insights on the heart failure management. To begin with, the agenda of today's meeting. First, there will be a speaker session by Dr. Sunil Sathe sir on a clinical topic of congestion in heart failure clinical approach, followed by Dr. Sachin Patil sir will share his expert insights on the one of the pillar of GDMT, that is RNA, its uses in HF, and followed by the expert panel discussion. Our today's esteemed moderator, Dr. Sunil Sathe sir from Pune. We have our speaker, Dr. Sachin Patil sir from Sachin Super Specialty Hospital, Kolhapur. Our expert national panelists today, we have Dr. C. Raghu sir, a senior interventional cardiologist, Yashoda Hospital, Sikandarabad. Dr. Manoj Durairaj sir from Pune, a President Indian Association of Cardiovascular Thoracic Surgeon, a CVTS surgeon, sir. Dr. Nikhil Kumar, sir, Director Cardiology, Fortis Memorial Research Institute, Gurgaon, and Dr. K.S. Poddar, sir, a Senior Interventional Cardiologist, ILS Hospital, Kolkata. So with this, now I request our today's esteemed moderator, Dr. Sunil Sathe, sir, to please start the session with his session on congestion in heart failure. Sir, please.
Yes, sure. Good evening to all. I think today we have an interesting symposium. We have two short talks. I'll be just speaking on a clinical topic of congestion in congestive heart failure, followed by Dr. Sachin Patil, who will speak on the recent aspects of ARNI. And we have four experts with us, Dr. Raghu, Dr. Durairaj, Dr. Kumar, and Dr. Poddar, who will actually give us insights, on the on this particular topic. So what we will do is, I will start with my first talk. First, we'll finish the talks, and then we'll go on to the panel discussion where, all the expert panelists can, I'll moderate the session, but they will be given their comments on several aspects of heart failure and ARNI. So let me start with this first clinical talk. This is congestion in heart failure. I mean, this is a very simple talk actually, but why is this important? We'll look at the definition, classification, pathophysiology, assessment, and treatment. It's interesting, the definition of congestion, it was just out of interest, I have shown this, is basically fluid accumulation in the intravascular and interstitial spaces due to increased cardiac filling pressures in the presence of maladaptive sodium and water retention by the kidneys. Now, why is this important? Because if you see ADHF, 83% are admitted with congestion. They have the symptoms of dyspnea and edema. The main reason for this talk is that if you do incomplete decongestion in the admission, then the incidence of rehospitalization and mortality is high in the first 3 to 6 months. And that is why this simple talk of congestion, congestive heart failure. In fact, we are treating congestion all the time. I mean, there's nothing new to tell you, but a lot of interesting things which I would like to quote. Starting with the three simple clinical points, Forrester's classification we all know. My aim in my clinic is to keep the patient warm and dry, not excessive diuretics, not wet, not cold. And we know cold and wet is obviously the worst clinical segment. Why is this important? Stevenson, the same classification, he actually gave us with this dry, warm, cold, and wet. He just told us what is the likely therapy, which I am not going to details, but is the first clinical thing I would see in my patient of heart failure: warm, dry, wet, or cold. That's one. Number two, so interesting of orthoedema score. This just to highlight the point that if you compare edema and orthopnea is more sinister. And see this. So if you have severe edema or orthopnea, it is grade 2. When you have orthopnea, edema, and orthopnea, it is actually higher grade. So orthopnea is given more significance, and that is why when a patient is discharged also, clinical edema may come late, but orthopnea may come early. So this is the clinical significance of this score, that orthopnea has been given more significance. Now, why are we looking at all this fluid overload and congestion? See here, every aspect, every system of the body is affected by congestion. Cerebral edema, end stage, a few things, cerebral obtundation at end stage heart failure explained. Myocardial edema, extremely important. first 24 to 48 hours, depending upon the myocardial edema, your inotropes may not give you the best results. Pulmonary edema, we know. Renal interstitial edema is a important part of cardiorenal syndrome. Hepatic congestion, we know it gives rise to decreased appetite and fullness of stomach with very small feeds. Gut edema, extremely important, because if you do incomplete decongestion and discharge the patient, the amount of oral diuretics required is very high because the absorption less because of gut edema and tissue edema, we all know. So every aspect of the system has some clinical implication in this congestive phase of heart failure. Classification, intravascular and tissue congestion. Now, what is the pathophysiology? We all know this. Activation of the renin-angiotensin-aldosterone natriuretic peptide axis, sodium water retention of the kidney, and one important point, it has clinical implication. Endogenous fluid reservoir, the splanchnic circulation, the splanchnic veins are an important aspect of as a fluid reservoir. What happens is the veins, the splanchnic veins have alpha receptors, and any surge in adrenergic activity suddenly constricts these veins and shifts the fluid from the splanchnic circulation into the intravascular volume, causing pulmonary edema. Why is this important? For two reasons. Number one, these so many patients which you see, hypertensive patients who go into pulmonary edema with not necessarily a very high blood pressure. It is not 240, 220, 240, but increased adrenergic drive. So a significant part of pulmonary edema with a high adrenergic drive, despite the BP not being in the 200s, is caused by this particular mechanism. The importance is nitroglycerin vasodilates the alpha receptors in this splanchnic circulation, and that's why it works in pulmonary edema, one of the mechanisms. Imbalance tissue congestion, hydrostatic and oncotic pressures. I am not going to details of this, but just to tell you four important pathophysiological factors, out of which, remember, lymphatic system is extremely important. It removes fluids, and that is why chronic congestion, chronic rheumatic heart disease, despite the LA and pulmonary artery pressures exceeding the pulmonary wedge pressure exceeding 25, chronically the lymphatic system removes fluids, and that's why despite the actually pulmonary edema point of 25, they will not develop pulmonary edema. That's one. And number two is vascular permeability is subset dependent. Okay, so diabetics, ischemic patients, and patients with sepsis can have vascular permeability problems, which will cause pulmonary edema at a lower hydrostatic pressure. Remember this. That's the importance of this pathophysiology. Clinical investigations, we all know this. I'll go into details. The only thing is, we all know this. I'll just speak a word on what is called bendopnea. Bendopnea means the patient, this is a very common symptom. Patient will complain when they actually bend down and do any activity, they'll become symptomatic. They become dyspneic. Bendopnea has three causes. Number one, decongestive phase of congestive heart failure. Number two, severe pulmonary hypertension. And number three, severe central obesity. So this is one important symptom which you should ask when you discharge the patient, that what is his symptom of bendopnea? It is decreased or that is increased. So that is why I've just shown you this clinical importance. Investigations, we all know, for intravascular congestion, simple NT-proBNP. Out of all this, I'll just mention a word of NT-proBNP. Remember, see here, out of all the trials from Paradigm HF to Galactic HF, remember, Victoria trial was the trial where the baseline NT-proBNP was the highest. That means more sicker patients. And that is why whenever you look at the results of any trial, look at the baseline NT-proBNP, number one. That's number one. And number two, you will find that if you give Versigod, and that is true for all, it's true for ARNI, it is true for SGL2, but specifically to Versigod, the decline of NT-proBNP is significant, number one, and that does translate into clinical benefits. So look at the NT-proBNP. This is an important marker of intravascular congestion, and its drop helps us in telling you that it will do that your drug is doing a good job. Tissue congestion, just a word, we all know this, Ralph's, peripheral edema, and ascites. One important point. Why in congestive heart failure, ascites is at the end stage? You never get ascites at the early stage of heart failure. It's at the end, very end stage. Why? Because for ascites, the sinusoidal pressure in the liver has to be high. And what happens is in the cardiac congestion of the liver, many times the sinusoidal pressure is not that bad because we decongest the patient. Again, the pressure decreases. As against that, in portal hypertension, the sinusoidal pressure is very high. And that's why you get ascites at the early stage and peripheral edema at the end stage. It's an interesting clinical point which you all know, just to mention for tissue congestion. Investigations, we all know this, but I just mentioned a word of thoracic impedance. A word. Here, today's devices, whether it is CRTDs, ICDs, and now even in pacemakers, you have got actually the programs which will measure the impedance. The lead measures the impedance across the thorax. It's not lead impedance. It is the impedance measured by the lead across the thorax, and it gives a beep. So you get a signal which will tell the patient that okay, his volume has increased and report to a doctor. So this is one implication of the investigations, the investigation of thoracic impedance, which has now come into clinical practice routinely. Finally, one word about the clinical matters is time lag between edema and the X-ray. That means the lung edema and peripheral edema. Remember this, that many times you will find when you diurise the patient, whether IV or bolus, you will find that the peripheral edema vanishes earlier. Sometimes it's a time lag between 24 hours to 4 days for your lung results to go either clinically or on X-ray. And that is why you have to be careful. Many times why this is mentioned, because we tend to decrease the diuretics very fast within 24 hours once the peripheral edema goes. So until your clinical you find that the lung, that is because that is tissue edema, it is interstitial edema. Until that decreases, your dose of diuretics should not be decreased significantly. So this is the clinical significance of lag between edema and peripheral edema and the lungs. Management, we all know intravascular congestion, natriuresis, and tissue congestion, fluid distribution. A few practical tips. We all know diuretics. Now look here, intravenous versus bolus, which is better in ADHF? There is no large randomized trial, but a lot of trials which clearly have mentioned that continuous intravenous drip is better than boluses for several reasons. Number one, boluses can give rise to sudden drops in your blood pressure, which again can compromise the kidney flow. Number one, and number two, there is a paper which has come that continuous drips cause the effect on the afferent and efferent arterioles of the kidney differently as compared to bolus diuretics. So both ways, intravenous continuous is better. Remember, withdrawal of diuretics has to be slow. What happens is, again, I'm mentioning, you have to look clinically at the lag between the lung and the peripheral circulation and then decide your diuretics at discharge. Word loop diuretics, whenever you find actually that the peripheral edema is cleared, the lungs are not clearing. In fact, one of the best combinations, a lot of 3 trials from Netherlands, which clearly have mentioned that if you have IV acetozolamide, 500 milligrams, and IV loop diuretics, it works the best. Unfortunately, India, acetozolamide is present as an oral drug, but it is not approved by the FDA for IV. But remember this, whenever it is approved, it's a good combination. Whenever you find a time lag, it clears the lung edema faster, this combination, as compared to any combination. That's number one. Number two, whenever it comes. And remember, a good, depending upon your clinical edema, furosemide, torsemide with metolazone is a good combination at discharge, depending upon, of course. And number last thing you must know as a clinical point is chronic diuretic therapy causes thiamine deficiency, which again is one of the causes of LV dysfunction. So just note this particular point. Limitations of natriuresis. Remember, electrolytes, we know plasma osmolarity decreases. It prevents interstitial fluid re-entering the bloodstream, number one. Increased renin secretion and increased serum creatinine. So we have a lot of limitations for our natriuresis. Remember this, but still it's the mainstay of our therapy with ADHF, but you must know this. And that is why aquapheresis, you must know this. Aquapheresis promotes excretion of free water. It increases plasma osmolarity, and that is why it increases the translocation of fluids from the interstitium to the intravascular space, and it avoids renal deterioration. Very important. So there are 2 aspects to ADHF, natriuresis, what we normally do, and aquapheresis. So what are the modalities of treatment for aquapheresis? 4. Number 1, vasopressin antagonists, that is tolvaptan. SGLT2 inhibitors. Lymph flow, uprinone is not available. Spanking nerve block we don't do, and ultrafiltration. Out of which the first 2 and the last one are important for us to remember. Remember one thing about tolvaptan. We all know tolvaptan is used specifically when your sodium drops. Okay, that we all know. So results are better with hyponatremia, no question, indication is there. But remember one more thing. A lot of papers are there where tolvaptan was given when the tissue edema, that means the lung was not clearing, the peripheral edemas were clearing. So whenever you find a patient who is taking a lot of time with diuretics to decrease the tissue edema, give tolvaptan even in the presence of normal sodium. A lot of papers are there which clearly tells you if you give in normal sodium, it doesn't cause hypernatremia. But you have to look out for that. Give it for 4 to 5 days. There are papers which have given this for 1 month also without hypernatremia. So this is called aquapheresis. So here tolvaptan is used as an aquapheretic agent rather than a agent for hyponatremia. So keep this in mind. When you have this particular type of patient, make use of tolvaptan. SGL2, of course, we are using in all patients of ADHF. But of course, depending upon when to start, it depends upon the patient's hemodynamic status. Now, aquapheresis. Remember this, aquapheresis. Aquapheresis is a predictable way of removing water from the patient from the fluid overload. Remember this. Now, this is was done for 2 decades ago. In fact, if you see the paper which compared, it decreases rehospitalization. It is amazing. It's an amazing therapy, for patients who are resistant to diuretics, number 1, or they have hyponatremia, or they have problems with creatinine, number 1. And there are a lot of papers. This is a recent paper, JACC 2020, which actually showed that it gave a comparison between natriuresis and aquapheresis, and clearly showed that the aquapheresis rate is, normally I have done around 18-20 patients. We have used this particular machine. It actually is simple technique. Just you have to have one line. Even a cubital line is okay, but I normally put a jugular line. You have to put 8 French sheet, simple, nothing else. Patient is mobile. There's no problem at all. And you can see the rate of removal of the from 500 ml to 4. In fact, the recent one, we have removed 6 liters in 2 days. The patients dramatically improve. This does not touch sodium, potassium. This does not increase creatinine. So remember this. What are the indications for aquapheresis? Resistant clinical edema, number 1. Number 2, in presence of hypotension where diuretics cannot be given, then you have to give a lot of inotropes. Hyponatremia, and whenever you find that the serum creatinine is rising because of diuretics. The classical clinical condition I'm telling you, creat is 3.5, patient has edema which is resistant. Now people start debating whether you can use CRRT or dialysis, use aquapheresis. The moment you start using CRRT or dialysis to remove fluid where dialysis is not indicated for 3.54, you will land into trouble. So use aquapheresis for that time. The patient's hemodynamics will improve and you don't require dialysis, number 1. Now people ask, suppose you do aquapheresis, why should the patient not reaccumulate? Now my first patient, you will not believe, was done almost 18 months ago. Resistant edema, he used to require admissions every 3 to 4 months. One aquapheresis, he has not required readmission, but he requires small dose of diuretics. Now, the mechanism mentioned that reaccumulation doesn't occur with aquapheresis is because it hits the renin-angiotensin natriuretic peptide system. There are sort of mechanisms mentioned. But that is why you must know about this modality now, easily available in India. It's a bit expensive, but still it's worth doing in this subset of patients. What you have to look at is just clinical, how much edema decreases. Hematocrit should not go more than 40. And the only thing you have to do is keep the APTT at 1.5 times normal. That's all. Okay. So coming back, last few slides, congestion, IV or oral diuretics, diuretic combinations, nitroglycerin for splanchnic nerve vasodilatation, tolvaptan, SGL2 as aquaretic drugs, and aquapheresis in a patient who has specific indication aquapheresis. I am telling you, it works wonders. I have a small experience of 20 patients only, but I'm telling you, many people may have much more experiences, but I'm telling you this works. And that is why this is the best way of treating congestion in congestive heart failure. Finally, 2 slides. Whenever you find failure of clinical response with all this, look at echo features, clinical echo disparity, and of course, it's end stage CHF. Few features, very low EF, number 1. LV disc, large apical disc kinase aneurysm. Basal septums move okay. echo looks not bad, but apical dyskinesis, people don't do well. Annular dilation and MR and RV dysfunction and PH, once that sets in, then it's through, then you cannot do much. So that is why before, even if you want to refer the patient for cardiac transplant, please do it before RV dysfunction and PH sets in, because so unfortunately, many times we have seen that patients are referred so late, the patient from cardiac goes into a heart-lung transplant, which is not worth. Finally, clinical echo disparity. Whenever you have end-stage optimal circulatory adaptive mechanisms fails, ARNI also doesn't do anything. They become vasoplegic. Anemia, salt, alcohol, NSAIDs, glitazones, diuretic-induced thiamine deficiency, chronic you must know, and ongoing ischemia. Just to conclude, ladies and gentlemen, this is a very simple topic, a very important clinical topic. We have several clinical modalities to treat congestion. Remember, congestion is intravascular and tissue congestion, and you can differentiate between these two depending upon where the fluid has accumulated, and you must use judicious use of diuretics or combinations. And please remember, concept of aquapheresis is very good in resistant edema, and whenever you find that the patient is having hyponatremia, creatinine is increasing, creatinine somewhere 3.5 or 4, where you can avoid dialysis and decrease the fluid volume overload. So a simple talk, a clinical talk, but useful for clinicians, and that is why I decided the first talk should be on clinical congestive heart failure. So I'll stop here, and now I'll invite Dr. Patil to speak on the second talk. Please, she stops in the.
So just to interrupt, Dr. Sachin Patil.
Sachin is there?
Yes. Sachin Patil sir got some emergency, so I requested Dr. Manoj Durairaj sir will take the second topic on the ARNI sir. Yeah.
Okay, no problem. So I'll invite Dr. Manoj Durairaj. You must know now he's the president of the most important surgical society of India. So he's my very close colleague and friend, and I must compliment him because he I decided no introductions, but I would like to mention this. Now he's the president of the Cardiac Society of Cardiac Surgical Society of India, number one. And number two, he is now into a lot of genuine MICAS, minimally invasive coronary and valve surgery. So I must compliment him. Of course, that is not the topic for today, but I will invite my friend Manoj to give a talk on ARNI. Manoj, please.
Yeah, thank you, sir. And as you were concluding your slides, I was told that Dr. Sachin is in an emergency, and I've been planted these slides. So, so please bear with me. I will try my best to make the talk meaningful. Can everyone see my slides? I had shared the screen.
Yes, sir. Yes, sir. It's visible.
Can you see it? And just one second.
Yes.
See this slide now?
Yes, sir. It's visible.
Okay. I have the pleasure of being the 55th president of our Indian Association of Cardiovascular Thoracic Surgeons. And Dr. Sathe has been my mentor and still my mentor. He's my guru, and he's been really protective of my career. And I'm really grateful to him and Madam Sathe for whatever they've done for me in my career so far. Thank you very much, sir. I'm grateful to you. I'd like to start by where Dr. Sathe ended the conversation. See, it's very important when we are discussing with you all on heart failure. There are stage A, B, C, D of heart failure. Now, there is a right time and an optimal golden window of opportunity before the patient gets into end organ damage. Either he has a stroke, or irreversible liver cirrhosis, cardiac cirrhosis, or irreversible renal failure because of end-stage heart disease or cardiac failure. We can push guideline-directed medical therapy to a certain point, but there is a chance of referring these patients to an advanced heart failure unit where the patients can go for an option of a heart transplant or mechanical circulatory support. I had the pleasure of writing this book chapter, and this was for the Indian College of Physicians academic wing of the API. And I just inserted these couple of slides in the talk, which was sent to me a few minutes back. And I'll take this opportunity to let you know that there is nothing like chronic heart failure which is stable. Heart failure can become unstable because of various parameters. And there's a beautiful article in JACC which clearly states them as frequent flyers. If there are patients of chronic heart failure there are various categories of chronic heart failure now. It is preserved, moderately reduced ejection fraction, or reduced ejection fraction category. They can get into a worsening heart failure category because of various parameters. It could be anemia, it could be arrhythmia, it could be renal dysfunction, it could be just a viral fever causing dehydration. So at each lowering of that cascade, there's a chance of higher degree of mortality. So our ball game is to prevent the hospitalization for heart failure, and that is important. So this is where we need to get into picture. Following which, once you have, there is where guideline directed medical therapy will play a role. After some time, you'll have to consider a heart transplant or a mechanical circulatory support. So this is a golden window for referral. Beyond that, as Dr. Sathe sir said, referral is too late. The patient can go into multi-organ failure, severe malnutrition, and severe cardiac cachexia, and that's because of the splanchnic congestion. Again, Sathe sir has clearly mentioned beautiful terms which we need to look at, and we also need to be sensitive about. So worsening heart failure is a problem. Now, heart failure in India. Professor Hari Krishnan, he led the Trivandrum Heart Failure Registry, and he was very clear. And that is the largest registry which we have in India. There's also Indus, there are a lot of other registries, but this is a time-tested registry. After the index admission for heart failure the first time, there's a 22% mortality rate if the patient does not receive guideline-directed medical therapy at discharge. So the facts are very clear, and there are still almost 58 to 60% of centers and physicians throughout the country and even the world who are not adhering or prescribing GDMT at the time of discharge to their heart failure patients. So we need to understand that there is a molecule called ARNI, there is a molecule called SGLT2 inhibitor, there is a molecule called MRA which has been there for a long period of time. There are beta blockers on board, and Dr. Sathe again mentioned a molecule called vericiguat which is there for worsening heart failure. In addition to that, in our armamentarium, we have to be careful about iron therapy. We have to be very aggressive about that. Ensure that the patient has a euvolemic status, and also it has to be a 360-degree approach. It just cannot be only ARNI, ARNI, ARNI. It has to be a 360-degree approach to heart failure. And please remember, there is nothing like chronic, stable heart failure. I won't get into the details, but definitely there is a worldwide population of around 30% which are prone for heart failure by 2025. And the patients have symptoms despite treatment. It's progressive, it's deadly, and of course, it's going to be costly. The foundational pillars are 4: ARNI, ACE or ARB, MRA, beta blockers, SGLT2 inhibitors. Now, of which ACE has been clearly replaced by ARNI in all the guideline directed medical, all the guidelines, whether it's EACTS, whether it's American Heart Association or the ACC, definitely ARNI has replaced unless there's a contraindication to having ARNI. This is the India Kerala Heart Failure Registry, and if you look at it, you'll find that the prescription rate is still low for heart failure with reduced ejection fraction for guideline-directed medical therapy. So what is ARNI? Basically, it is sacubitril valsartan. It's an angiotensin receptor neprilysin inhibitor. Valsartan, everyone knows, but neprilysin inhibitor is the combination, and that has become a milestone in the treatment of patients with heart failure with reduced ejection fraction. But heart failure with reduced ejection fraction is just one spectrum of heart failure. There are moderately reduced ejection fraction and preserved ejection fraction. The only molecule at the moment which has been effective in all ranges of heart failure has been SGLT2 inhibitors. But this talk is also to let you know that there are extended indications for ARNI now. It's not only that the Paradigm HF trial clearly showed that it's good for heart failure with reduced ejection fraction. Now there is a Paraglide trial which is showing that for heart failure with moderately reduced ejection fraction, ARNI is also the drug of choice other than SGLT2 inhibitors. Now, the evidence for sacubitril valsartan across the heart failure ejection fraction has been a little, suspect. It's skewing towards the Paradigm HF trial. But after following stabilization in decompensated heart failure and preserved ejection fraction, the trial which has come out is the Paraglide heart failure trial. The transition trial was for any patient who was admitted with acute decompensated heart failure, where we could start ARNI as soon as the patient was off inotropic supports, as well as once the patient was stabilized, but before discharge. That is very important. And the Paragon HF trial was basically closer to the time of a hospitalization event, whether there was a potential benefit. So there were ARNI outpatient, whether it is improved, keep it improved. In hospital, there was a Pioneer, Transition, and a Paraglide HF trial, and the Paragon HF trial, which was after hospitalization. So the incremental factors when you add an ARNI is almost to the tune of around 38%. And this is important of reduction in cardiovascular death and sudden cardiac death. Now, if you ask me whether we should be aggressive at the time of post-discharge of a patient with heart failure with reduced ejection fraction, maybe had a PTCA before, had a CABG before, and should we give these patients ARNI? Yes, because 20% of patients who come to us with reduced ejection fraction after having undergone a CABG or a PTCA, 20% have a chance of sudden cardiac death, and this is what ARNI can protect that patient against. ARNI also is proven to have a reverse remodeling effect. This has been proven by not only the LV ejection fraction, but the volume indices improve. It's not only the LV end diastolic volume index, the end systolic volume index is also the LA volume index and the E prime. So all this have clearly shown that from the baseline to 12 months, this is the actual improvement in the indices when you have such patients. So it's not only just subjective data, these are objective data. There are also cardiac MRIs which have done this study, and we also have PA pressures. That means you float in a Schwann-Ganz, and people have studied the reduction of the pulmonary artery pressures correlated with an ARNI being on board. Now, when you look at the slope of the decline of the EGFR, ARNI definitely reduces the EGFR slope decline, and that is seen in the Paradigm HF, and that is what the benefits are there for heart failure reduced ejection fraction. And maybe the potential mechanism is by improving the ejection fraction, improving the cardiac output, and that is where ARNI plays an important role. Now, the renal outcomes also out there for you to see in the Paraglide HF trial and the Paragon HF trial in moderately reduced and heart failure with preserved ejection fraction. And this is important in this talk, that there are extended criteria for use of ARNI now. We can talk about ARNI, that it can be used in a moderately reduced ejection fraction category, as well as a preserved ejection fraction category. And what we see is that there's a 40% risk reduction in renal composite endpoints. I won't get into these details, but it is improving the cardiorenal protection across the various continuum of cardiac of kidney risk, according to the various scores. And then ARNI definitely reduces the cardiovascular death and heart failure hospitalizations in patients post-revascularization, whether it is PTCA or whether it is CABG. Introduction of ARNI for this category of patients, whether it's pre-op or post-op, maybe we'll take it up in the panel discussion later, but it reduces the risk of cardiovascular death and heart failure hospitalization in this particular category. Now, what about this Paraglide HF trial? This is a very important trial. It is used for mildly reduced or preserved ejection fraction patients. And this is where the extended use of ARNI comes into play. Now, ARNI can be used in patients with LV ejection fraction more than 40%, and that is what this meta-analysis shows. So Paraglide HF trial took 466 patients with recent worsening heart failure events that is defined by heart failure hospitalization, urgent heart failure visit, or an ED visit within 30 days after the index admission. The Paragon HF trial was 622 patients with recent heart failure hospitalization with less than 30 days. That is like it almost considers an in-hospital kind of issue. So when you look at the total pool of 1088 patients, they looked at the primary endpoints of total worsening heart failure events or cardiovascular death, and they found that just using valsartan or using ARNI changes the game, and you'll find that the numbers needed to treat are 27.5 here and 34.5. So obviously there is a huge benefit of using this molecule when you have and this is the forest graph, which shows that there is a favoring towards the sacubitril valsartan, that is the ARNI group, for the patients in this category. And the summary was that there is evidence supporting the use of ARNI in patients with heart failure with mildly reduced or preserved ejection fraction, particularly among those patients where an LVEF is below normal, regardless of the care setting. I won't go into this detail. What is the other extended category? Now, you might say that this is going to become controversial, but let us take it up in the panel discussion with Sathe sir. Will talk to us about, can ARNI be used in patients who have essential hypertension? And you'll all agree with me that hypertension is the leading cause of coronary artery disease, which is the leading cause for heart failure. So if you're able to have a combination of ARNI for hypertension in heart failure, I think that is the best bet. In fact, the best outcome for patients, at least in my clinical practice, are patients who are having hypertension and heart failure when we are treating them with ARNI. So ARNI in hypertension with heart failure, what is the level of recommendation? It is a 1A level of recommendation that in patients with heart failure with reduced ejection fraction, then you should substitute ACE with an ARNI and also have other guideline directed medical treatment, the other three pillars. So is ARNI approved in hypertension? Yes, ARNI can be used as a new indication and a new dosage for hypertension from the Japanese group. It has received an indication approval from China and Russia. So comparison with sacubitril valsartan and olmesartan for hypertension, they have found that definitely it favors ARNI. So I just won't go into these details so that we can take a few more questions on the panel discussion. And talking about the salt, definitely, if you look at sacubitril valsartan, what the salt which we are discussing. Okay, so this is a 1:1 molar ratio as compared to the Innovator brand, and it's got a good solubility profile and it's got a higher dissolution rate. And there's also an enhanced bioavailability of valsartan. So definitely the molecule which we are considering right now is equivalent to the Innovator brand. And I've also been told to speak about this thing, that there is none of the product had the same innovative crystal lattice as that of Azmada. So we are being sponsored by Azmada, and I have to tell you one thing, that it is a 1:1 molar ratio, and it is a good solubility profile, higher dissolution rate, and it has got the same innovative crystal lattice as that of Azmada as compared to the Innovator brand. It also has twice more the sodium content than the Innovator product. So I think end my talk with this so that we can go ahead with the panel discussion. And If you look at the comparative analysis, definitely it.
Sir, सांगतो काय what do's and don'ts. Yeah.
So, Dr. Sathe sir, I think I'll go on to your panel discussion here, and I'll end my talk. Thank you.
Okay. Okay, thank you. We must appreciate Manoj, because at the end, you have given an excellent talk covering all the aspects of ARNI. So now we actually go to the panelists. I think this is an important talk. So I'll start with one or two questions on congestion, and then of course we'll go on to ARNI main actually. So Dr. Raghu, in your practice in ADHF, what is your choice of the intravenous diuretic? Whether it is torsemide, furosemide, you have any choices specific, or is it okay that you can use both? Just your comment on that.
My practice is been using intravenous torsemide as a bolus followed by an infusion in my daily practice, and that has been there for close to a decade now. And the tips what I use to implement, I implement in the when I use the diuretic is, I always use a natriuresis guided approach. That means once I start the patient on IV torsemide, I get a urinary spot sodium at the end of 2 hours. And if the urinary spot sodium is around 80, 60 to 80 is the target what I would like to achieve. And if I'm able to achieve it, I will continue the same dose. If I'm not achieving, it's around 40 or 35, or in that range, I will double the dose of the furosemide. So I have an objective basis for the up titration of the dose of the parenteral diuretic. That's what I use.
Thank you. Dr. Kumar, just one question on a diuretic issue. It's a diuretic issue. In your OPD, in your chronic, when you are actually looking at eplerenone versus spironolactone, Dr. Kumar, what is there the choice between the two, or what is your choice, or you think both are the same when you are using these drugs, whether it's eplerenone or spironolactone? Dr. Kumar?
Yeah, so I really don't distinguish too much between the two. Of course, there are subtle differences. I know that, but of course, if the patient has any contraindications or side effects from spironolactone, definitely move to eplerenone. And of course, having said that, now we have a non-steroidal MRA also, which is now going to come into focus with the new data coming in from the fine arts study. And so we have finerenone also in patients with diabetes, CKD, and possibly patients who with preserved management of preserved ejection fraction heart failure.
Okay, thank you. Dr. Poddar, just one last question. What is your idea of complete nephron blockage? Now, how many patients you look at the whole loop, whether the complete nephron blockage, how many patients do you think you have to use this particular concept? Dr. Poddar?
It all depends on the depends on the renal function of the patient. I take into account the creatinine, the eGFR, and then I decide on that, sir.
Okay, fine, fair enough. So you look at the hemodynamic status and the metabolic parameters of the patient, and then decide whether he requires 1, 2, 3, or 4 diuretics. Okay. Now we move on to the main talk of today. That is ARNI. Now, Dr. Raghu, in your practice, first I want all three of you to answer. 4 pillars, optimal dosages. What is your percentage of patients achieving? Just quick, all 4 of you. You can start with yes, Raghu.
I think 40%.
40%.
By mind, of course, if you're looking at ARNI, 200 milligrams twice a day is not very frequent, but I have a large number of patients on 100 milligrams twice a day. And of course, we have one small set of patients who really do not tolerate things. And then we, of course, start them on a very low dose on 25 twice a day and try to up titrate. But 200 milligrams twice a day of ARNI, because the others don't require too much of a dose up titration. So I think we hear the molecule in focus is the ARNI, and I would say about 25 to 30% patients are on 200 milligrams twice a day.
Absolutely. Dr. Poddar?
Yes, sir. I try to use the four foundational therapies in all my patients by starting with a very low dose, because I find that and the literature also tells that low doses of foundational agents reduce morbidity and mortality, and the foundational therapies have benefits, provide benefits of each drug class for heart failure with reduced ejection fraction, and these benefits are independent of each other. So we can start with the four foundational therapies with a very low dose, and then we can titrate.
Okay. Now, just quick again, coming to the same, only specifically ARNI, Dr. Raghu, 50 BD, 100 BD, average dose, and how many of the patients are below 50 or say 50 half BD? Just quick, I mean, we know it depends on hemodynamics and so many other factors, but just to know that what is your, Dr. Raghu, 50 BD, 100 BD?
0 less than 50. About, if you take a chronic heart failure patient, almost 80% of them are on 100 BD. Quite a few of them are 200, 100. And about a percentage, about 10 to 15% of them are on 200 BD.
Dr. Kumar,
But none less than 50.
do you start with 50 half BD in at least, you know, those really sick patients, Dr. Raghu? Dr. Kumar?
No, not exactly. I mean, see, as once the patient is coming out of an ICU setting, or basically patient is, has a reducing dose of diuretics, patient is relatively isovolemic, and we have no contraindications on the potassium levels, and the blood pressure is well maintained. I mean, the minimum dose one would start is 50 milligrams twice a day. We have a certain number of patients who do not have any contraindications and who were on antihypertensives. There one would start with 100 milligrams twice a day.
Okay, fine. Dr. Poddar, quick comment.
So most patients of mine have with heart failure have low blood pressure. So many patients I initiate with 25 milligram twice daily, that is 50 half twice daily. Then I try to up titrate.
Okay, fine. Okay, next the parameter of ARNI is CKD and ARNI. Now, what is we all know EGFR and EGFR less than 30. So, your parameters for CKD. Now, suppose you start a patient with 30, Dr. Raghu, do you look at the creatinine level? This is because there are a lot of physicians who have joined. Many people, we know it's EGFR. What is the parameter you have to look at? Are you going to look at creatinine, only EGFR? And what is the rise where you stop ARNI in a CKD patient? Dr. Raghu will have a quick comment on all. These are important practical points.
Yeah. I think less than 30 EGFR, I do not initiate an ARNI. That is the number one parameter what I see. So, for example, if the GFR is less than 30, I still continue 50 BD, but I will not start to initiate the patient. That's number one. Number two is what is the if the GFR or the serum creatinine, I think GFR becomes a very tough parameter. It's not a right parameter for me to monitor it. So whenever I initiate and look for the renal parameter worsening, I look at the creatinine. If it is more than 100%, I stop. 100%, that is double the number of the resting, I stop it. If it is 50% rise, then I would prefer to up titrate the this one. 50 to 100, I take a one by one, case by case approach.
I think very important is important. Dr. Kumar, quick comments on this because this is a very important issue. People are paranoid about serum creatinine, CKD, and ARNI. So, we must tell them that initial rise, you have to be careful, but you should not stop because, if you improve the hemodynamics, eventually it will improve. So, Dr. Kumar, quick comments on CKD and ARNI.
It is expected to have a, kind of initial rise. I think up to a 25% initial rise one would accept. But if there's a rapid rise or, your potassium levels again are very important, do not permit it, then one would go cautiously. If the patient has a EGFR of less than 30, I do not normally start with this thing, with an ARNI. I probably would go for a hydrolazine instead, and then just see how the hemodynamics behave, how the creatinine behaves, and then ease on to an ARNI.
Okay, Dr. Poddar, quick comment.
Yes, sir. I find that creatinine 2.5 and a potassium level of more than 5.5, I do not, I'm hesitant in introducing an ARNI. Let the creatinine come down and the potassium come down, then I'll introduce ARNI. That's my philosophy, sir.
Correct. So you should be careful about EGFR, serum creatinine when you look at the rise, and of course potassium more than 5.5. Important clinical tips. Okay, now again coming back to ARNI and EF. Dr. Raghu, initially, we used to look at EF and we used to be amazed. Now, remodeling parameters, we all know there's a lot of theory and a lot of papers of remodeling and ARNI. Really, do you really look at these remodeling parameters or you look at the EF? And how do you go about looking at the EF, or you are really into the different parameters mentioned in all the papers?
I
Practical.
think practical, yes. My predominant parameter would be ejection fraction less than 40. Start on ARNI. Between 40 to 50, maybe ARNI based upon the patient's BNP and congestion state. Above 50, I'm very cautious. For HFpEF, I'm very cautious unless the patient has got lot of congested symptoms to start the patient on an ARNI.
Okay. Dr. Kumar, just your quick comment on which subset of patients you would think of starting ARNI in a heart failure with preserved EF. Dr. Kumar?
Well, I normally, practically going by the fact that, I would look at some parameters of diastolic dysfunction, and especially the patient has a raised LVDP on the echo. I mean, I take that as a significant reason to start an ARNI, and then I would also like to, in these patients, do an NT-proBNP.
Okay. And Dr. Poddar, again, your comment on EF. Do you look regularly at the EF at what time, and what is your experience of EF and ARNI?
Yes, sir. I check the EF, but not only EF. In the back of my mind, in all our mind, we should understand that ARNI improves the prognostically, it improves the heart failure, and it prevents sudden cardiac death.
Okay.
So,
Now coming to Dr. Dorairaj or Manoj, see, you have so many patients. You do CABGs on patients with LV systolic dysfunction, 30, 35, high risk patients. So what is your approach to these patients? What time would you think of initiating ARNI post discharge? Manoj, please.
Yeah, so I think that's a very important question, because if a patient is stable preoperatively, I would prefer to start ARNI, in fact, preoperatively also, as soon as possible if I get a window of opportunity. How long before the surgery? I think if the patient allows me, maybe even a couple of weeks, 3 weeks, 4 weeks, whatever, because if the patient is congested and overloaded, obviously we need to treat the congestion first and make the patient stable before he goes for surgery, rather than have a hot CABG on the table with a lot of supports and IABP. So I have started treating them acutely and then managing them for maybe even 10 to 15 days or maybe 3 weeks with GDMT. And we've been seeing that I can manage these patients off pump and without an IABP if they are optimally stabilized prior to surgery. Stopping ARNI is very important because there's a vasoplegic effect during the perioperative period. So at least 2 days before, because the washout has to be there. It holds the same with SGLT2 inhibitors, the same concept as valsartan, telmisartan, or any of the ARBs. We should stop them a couple of days before so that there's no vasoplegia, because that's very difficult to treat. The only thing which works during surgery is vasopressin. Post-operatively, once the patient is, I wouldn't start ARNI in the recovery room, but once the patient is off supports, I would definitely start them on an SGLT2 inhibitor. And prior to discharge, if the renal parameters, hemodynamics are good, then definitely I would ensure that the patients are on GDMT how much ever possible before they go home. So that is what my criteria is, and that will carry on because the long-term legacy of patient on guideline-directed medical therapy is much, much better. I would not stop the ARNI for these patients. Because as I think Dr. Podar also mentioned, chances of sudden cardiac death are very high. Chances of repeat heart failure hospitalizations are very high for these patients, whether it's PTCA or CABG. So we have to have them on GDMT, sir.
Okay, thank you. That's what the important thing. That means even post-surgery, in fact, that's an important, RNA has an important, or GDMT, I would say, has a very important contribution, which we should not neglect. Because what happens when surgery is done, patient is okay. In fact, we think that everything is okay, and that should be actually emphasized to the patient that no, they have to be on adequate GDMT even after the surgery is done, especially in all those patients who have an EF between 30 and 35 or less. Thank you. Now, one quick question, Dr. Kumar. Have you seen that, your incidence of ICD implants, transplants has gone down after GDMT and especially ARNI and GDMT, of course, the optimal dose because of improvement in LV function? So what do you think is your comment on that?
I don't think I have enough data to support that, but yes, anecdotally, we have seen patients who have improved EFs, and we have not had a need to put in a device because the EFs did improve. One has to be a little careful on this, interpretation. I think without going into extensive diagnostics, is that did the patient have any inflammation, or was the patient, had some ischemia? Then again, post revascularization, have you waited enough for the EF to come up? So we have a lot of confounding factors in this, just the EF itself for implanting a device.
Dr. Raghu, quick comment on this.
I think we had made tremendous progress with the implementation of GDMT. We have data. So the mortality of 50% mortality in 5 years is now 85% to 90% survival. That itself obviously leads to reduced patients being referred for cardiac transplantation or MCS and all that. So we have made a lot of progress with the GDMT.
No. Dr. Manoj, coming back to you. See, a lot of rheumatic heart disease patients, chronic AFibs have low EFs. So when you're operating these patients, even is that subset also important for you to start GDMT and ARNI, and what do you do with that subset of patients?
I think
Rheumatic heart disease.
I think that's a fantastic question, sir, because we have a huge subset of patients with valvular regurgitant lesions, actually, not the stenotic lesions. Stenotic lesions will definitely improve, but you have severe MRs with, there's an output mismatch on the echo. And these patients, you start them pre-operatively, the LV ejection fraction is 60%, but I go by DP by DT. If I find the DP by DT is around 600 or 500, 400, LV is struggling, you start them on GDMT for a month. Frankly speaking, if you find that the DP by DT is improving to 1000, 1200, you know that the patient is really going to rock off the table. I mean, do very well. And that will hold on, maybe because of reverse remodeling. I don't know. Maybe because of the LV picking up. I really don't know. Rheumatic population. But these patients do very well. So I think that's a beautiful subset which you're discussing. Rheumatic heart disease, severe MR, severe AR patients coming for surgery. GDMT definitely helps in optimizing them prior to surgery and keeping them, in fact, symptomatically better, sir. Even post-surgery, sir.
Yeah, and again, I'm asking you the same question because, see, you are a transplant surgeon. You have done so many cardiac transplants now, and you have been doing it routinely. So have you seen this, at least I would say, postponement of the transplants, or maybe off the list because of GDMT? Because so many people are referred to you. So what is your take on that?
I've had 5 patients, I mean, in my list who have come off the list, sir. I mean, come off the list means they have actually, there was one patient who came for transplant. There was an HLA positive match on the table, and that patient went off the list. And for some reason, that patient was on GDMT. Now it's 2 years. His LV is actually improved to 45%. He is able to walk. He's able to climb 4 stairs and 4 flights of stairs. And it's actually on the transplant, but came off on the table. So definitely it improves. I mean, I'm a transplant surgeon. I won't say anything worse than that. But even the patients whose LV doesn't improve, the actual quality of life also improves. It also helps us on maintaining a patient on the waiting list, survival till they get a transplant. That's also very important, sir. Keeping the patient till they get a donor is also important. So these two category of patients is what I'm looking at, sir. One is they have gone off the list. I agree, a small subset. But the guys who actually have to come for transplant, it makes them survive till the time of transplant.
Can I make
Okay, now, yes, yes.
So, I mean, in this regard, we've had some patients, again, anecdotal reports where patients have improved dramatically, if not the EF, then the symptomatic status, I mean, we had this patient just recently when this patient was, came in from abroad and was doing very poorly, and we started the patient on ARNI. And day 3, the patient comes back, you see, I really need something. I'm okay. And similarly, we've had patients who did not tolerate ACE inhibitors even in small doses. So those, when we shifted back to ARNI, of course, we had to start with small doses, are tolerating ARNI almost up to 100 milligrams twice a day. So this is another thing I've noticed with, ACE inhibitors versus ARNI.
Yeah, thank you. Now, again, just one quick interesting question I want Dr. Raghu. See, sometimes you find young people, we label them as DCM, mostly they have viral myocarditis. And sometimes we find that their EF dramatically improves, It is 25-30%, it becomes back to normal. Now, such patients, what happens to your GDMT? We all know that GDMT should not be sort of reduced. But these people who come back to normal within a month or two, we find them. What do you do, Dr. Raghu?
It's a tough question, Dr. Sunil. But I used to stop 5-7 years ago, and I had bad experiences with those patients. So I realized that it is better to continue the medication. Sometimes nowadays I get a cardiac MRI done. If the structural changes are not there, sometimes I get into the mind that possibly can we stop or reduce the GDMT. But honestly, I could not stop them because I'm very apprehensive to stop these medications or reduce the doses.
Dr. Kumar, your comments on reducing doses of any GDMT, and what you do, you would like to keep the same despite the EF? What is your take on that?
Present day practice, I try to continue GDMT, except for, of course, diuretics are not a part of the GMT, so they're off diuretics. And I'm not sure about the MRA in these patients, but at least the 3 beta blocker, ARNI, and an SGLT2 inhibitors, I do always continue if there are no contraindications.
Thank you. Dr. Poddar, just want to diuretics.
Sir, can I comment on this young patient? Some of patients, I mean, other than cardiac MRI, we've done PET scans for sarcoidosis also, because those are obviously, and they dramatically improve with steroids also. So, I mean, that is a subset of patients which is reversible, sir. And some of them have ended getting this CRTs and all at a very young age, and pacemakers. Most of them have syncopal attacks and come to us, sir.
Yeah, so we actually picking up more with sarcoid as we're going along. It was probably undiagnosed earlier, especially you have a particular kind of a pattern on the echo, and then of course, and conduction abnormalities or arrhythmias. These are the patients I think you should screen for a sarcoid.
Yes.
Yeah, I think we have an excellent discussion with all the panelists. I think it's already 8 o'clock. Dr. Komal, you want to give your final comments?
Yes, sir. Yes. So thanks a lot, sir. So on behalf of JB Pharma, I would like to thank all the experts, respected doctors, for sharing your expert insights on this management of heart failure. Thank you, sir. Special thanks to Dr. Sunil Sathe, sir, for moderating the session, and Dr. Manoj Durairaj, sir, for the last moment support for taking the ARNI sessions. Thank you. Thanks a lot. This will guide the physicians and help them to uses of ARNI and managing the clinical congestion in heart failure. Thank you, sir. Thanks a lot.
Thank you. Bye-bye. Good night.
Bye, sir. Thanks, Dr. Manoj, sir, Raghu, sir.
Yeah.
Thank you, Dr. Poddar, sir. Bye, sir. Thanks, Dr. Nikhil, sir. Thanks a lot, sir. Thank you very much, sir, for the last moment help. Thanks a lot.
Pleasure. Okay. Are we offline?